My guest today has written a landmark book that tells the full story of racial health disparities in America, revealing the toll racism takes on individuals and the health of our nation. My guest is Linda Villarosa. She's the author of Under the Skin, the hidden toll of racism on American lives and on the health of our nation. And she joins me coming up next.
Live from Los Angeles, this is the Special Report with Areva Martin.
Linda Villarosa is an award-winning writer at the New York Times Magazine, and she is a contributor to the 1619 Project. Super excited to sit down with her this morning and talk about her new book, Under the Skin. Good morning and welcome, Linda.
Good morning. Thank you for having me.
So, Linda, there are a lot of books out about health disparities, about race and the intersection of race in the healthcare system in the U.S. So why this book, Under the Skin, and why now?
Well, I've been looking at this for a really long time, beginning when I was a young editor at Essence in the late 80s, all the way till now at the New York Times Magazine. And what I found was most people get the wrong problem. They get the problem framed wrong. So it seems like when you look at racial health disparities in America, starting in birth with infant mortality, where we have so much higher rates as Black people, and maternal mortality, where the rate is rising and 3 to 4 times greater than in white women, all the way to life expectancy, where we live 6 fewer years. And then it turns into either 2 problems. 1, something wrong with our bodies, like something genetic or inherited. Or 2, something wrong with us and our culture, something we're doing wrong to cause these racial health disparities. And what I believe is that we are doing our best. We're trying hard, but there are forces against us, both in the healthcare system itself and in society, that cause these racial health disparities.
You know, I'm thinking about our former U.S. Surgeon General and the comments that he made about African Americans and lifestyles during the kind of the height of the COVID crisis. And I was just reading an article, I think it was in the New York Times, about how difficult his transition has been since he left the Trump administration. He went months without a job. Big universities and hospitals and places that would typically, eat up a U.S. Surgeon General were not welcoming to him. He finally, I think after 8 months or so, landed at a university in Indiana, I believe. But he was perplexed by the taint of Donald Trump. And I'm just thinking back to his comments and what you just said, that typically when there's health issues related to African Americans, there's usually something wrong with us, i.e. our lifestyles or our bodies. And that's what that Surgeon General said in that moment about Blacks and lifestyles that got him, oh man, in a lot of trouble with Black folks and with lots of folks. But why is it a doctor like him? He was so well trained, well educated, made it to the highest position I can imagine that a doctor can achieve in this country. But yet he still, is parroting those racist tropes about Black folks.
I think it's just so common. That is a misconception that many people have, including many like Dr. Adams, who are part of the healthcare system. It's particularly saddening for someone like him because he grew up in a disadvantaged situation, and he also had many of the same health problems himself. So I don't like when people blame themselves and their communities for their problems when it really is something else going on in America.
Yeah, I was kind of shocked that he was shocked that he would not be met with, welcoming arms. I don't know what he thought working for Trump and being a puppet in that way would do for his career, but obviously he's learning. I do want to read something that's in chapter 1 of your book that I found really fascinating. And it says, much of what I believed about health disparities and inequity in the United States was wrong. The something that is making Black Americans sicker is not race per se, or the lack of money, education, information, and access to health services that can be tied to being Black in America. It is also not genes or something inherently wrong or inferior about the Black body. that something is racism. Income, education, determination, and self-empowerment can help individual Black Americans, but cannot entirely erase the negative effects of centuries of discrimination and ongoing bias on the health of African Americans. That's such a simple yet profound statement, Linda. Why is it that after decades and decades of research and researchers, telling us that race has, a negative impact on our health, do you think we are still in denial about the very statement that, starts chapter 1 of your book?
Well, I think that we're in denial for two reasons. And part of it is ourselves. I don't want to think about what fighting against discrimination day in, day out is doing to our body, because it feels like something you can't control, or that when you enter the healthcare system to get treatment and care, many times people like us are not treated the same and aren't treated fairly. And that's a hard thing to swallow. And then I think in America in general, racism, there's a complete denial about the centuries-old effect of discrimination and racism on those of us who have been dealing with it since 1619, when we first came to this country. And I think it's such denialism. And so I understand why people don't want to hear it, don't want to talk about it. And that's why in my book, I really use a lot of research data and evidence to show that this is real. And still, sometimes when I'm giving talks about it, someone will say, oh, I think you're right, but we just need more evidence. I remember just a couple of weeks ago, someone said that to me, and I was not cool at all. I just went, no, we aren't. No, we don't. We don't need any more evidence. It's right there. It's hiding in plain sight.
Yeah, you mentioned a couple of things I want to follow up on. One is this notion about education. So it doesn't matter in many instances what your education or income level is. And I know you wrote a really groundbreaking piece of journalism, article about the Black female or Black maternal death rates and how dangerous it is for Black women to have babies in this country. And again, one of those things that we've known, the data has proven for years. But what do you think was so powerful about your article? I mean, obviously you wrote it, so it was very powerful. But why do you think it resonated in the way that it did? Again, given that data has been available for so long.
Well, I think because it went against the grain. The assumption is that we as Black birthing people are doing something wrong, and that is what is going on, or that all of us are poor and we don't have access to health care, where in reality, a Black woman with a master's degree, a JD, PhD, or an MD is more likely to die or almost die related to pregnancy and childbirth than a white woman with an 8th grade education. And then the disparity, the racial gap, is actually wider at the more educated level. So then it means that people have education, access to education, and being educated means access to health care, means that you know what to do during your pregnancy and during childbirth, may mean that you're at a better hospital or have a better doctor. Yet why is the disparity greater when the only thing different in the groups of women is the race of the mother? And so that was so shocking to me that I wanted to really understand what was going on. And it's shocking to a lot of people.
Yeah, I'm shocked, because are you saying, Linda, that as you get more education as a Black woman, your chances for dying in childbirth actually increases?
No. So what it is that your chance of dying in childbirth relative to a white woman who has the same level of education is much greater, but also it's greater than a white woman with an 8th grade education. So but we're still, if an educated Black person is still less likely to die than someone who hasn't had the benefit of education. So it's not that it's worse among groups of Black people, it's just the racial disparity is surprising.
And does that go back, Linda, to this myth that, again, has been disseminated for years, that somehow Black women's bodies are more, that we're tougher, that we don't experience pain in the same way that white women do, that we can endure pain, that, I don't know, our skin is thicker, whatever these tropes are. Do you think that's tied? Does your research show that that's tied to why women die in greater percentages? Black women, even Black educated women, die in childbirth in greater percentages?
Well, I think that's part of it. And you have to look at the case of Serena Williams to see that her legitimate claims of, what was going on with her body during childbirth were ignored. And, when she's someone who knows more about their body as a elite athlete than anyone on the planet. So something happened there, and it could be related to one of those myths. But I think the problem is threefold. One is that there is a phenomenon called weathering, and weathering happens when you're a Black person, especially a Black woman, who is fighting against discrimination day in and day out, and it causes a kind of premature aging on the body, kind of a buildup of toxic stress when fighting back against racism way too often. And that kind of stress shows up in what is essentially a stress test, which is pregnancy and childbirth. The second thing is we simply live in communities far too often that are disadvantaged, not because of something we did wrong, but because of centuries of segregation and discrimination, often by the government. And the third is when we go into the healthcare system, like we were talking about, it is very clear that we experience discrimination and some often mistreatment. So between the three things, it's hard for us to get a fair chance when we're going to have a baby, which should be the best day of our lives, not turn into some tragic near-death or death experience.
Do you think women, particularly educated women, does your research bear out that when they are in these healthcare settings, that they are reluctant to push the system to advocate for themselves out of just kind of a resolve that it won't matter, or, my voice won't be heard, or I'm fighting this big system and I can't win?
I think sometimes, but I think sometimes it's fear of anyone who goes in the healthcare system to have a baby or wherever you're going in is afraid. Black people have much more reason to be afraid of mistreatment because of the evidence that shows that it happens far too often. But I think the worrisome thing for me is that when we do speak up, we're ignored. And that's what happens with Serena Williams. And though this isn't with childbirth, it happened to Dr. Susan Moore when she went into the hospital in 2021 with COVID. She's a physician. She pushed back against, she was saying, I need pain relief because I'm in a lot of pain. She was treated like she was drug seeking. And she put her video on Facebook Live of herself in the hospital bed saying, this is how Black people get killed. She, in fact, did die. And afterward, in an investigation of the hospital system, and remember, she was a physician, in investigation, one of the things that happened was the investigation found that part of the reason she wasn't listened to was because the healthcare providers that were supposed to be taking care of her were intimidated by her level of medical knowledge.
Say that again.
It's so hard to believe.
They were intimidated. So what? I'm intimidated, and I.
So I'm not going to listen to you, or I'm not going to treat you the same or the way you need to be treated, even though in this case you're a very educated patient. You're the most educated patient because you're an actual physician in the system in the same state where you practice.
Okay, and that conclusion was reached to absolve these practitioners of any liability, or to
it was among the list of reasons. And when I saw that, you're reading the list, I was like, wait, what? Being smart and knowing about, medicine and being an actual doctor is a form, it doesn't benefit us.
That's a mark against you, where you would think the opposite would be that they see a physician and say, let's collaborate. I know you have some experience with X, Y, Z, and I have this experience. So let's, talk about this in a way that gets you the best medical outcome.
I think this issue is...
believe that some white man walks into a hospital room and sees a Black physician and is intimidated, but I don't know.
That's
need
hard,
to read
right?
that report, and I'm having a hard time
I know
that could even happen in this country. I could see them dismissing her, in the same way they dismiss Serena, despite her education, despite her fame, despite her money, or perceptions about her status. But okay,
but dismissal is a form of not listening to you. So I wasn't in the room. I don't know exactly what happened, but I did read that report to say that about the intimidation. And so if someone's telling you what they need, I don't care if you are a physician or not, you should listen, because any human being knows more about our own body than anyone else. And
yeah, no, I'm not suggesting that you're not telling the story correctly. I guess I'm just so, flabbergasted at the concept that a physician walks into a room and sees another physician, and that doesn't lead to instant some kind of collaboration to get that person the best healthcare. But let me ask you this, Linda. I know that you've been writing on these issues for a while, going back to your Essence days, writing about that intersection of health and race and social justice. Have you seen any improvements? Is anything getting any better? Is the medical system listening to us more now than, say, they were a decade ago?
Oh, I really think so. And this semester at my college at the City University of New York, I'm teaching pre-med students, and I'm teaching them about, sort of the ideas of my book. And I see a real hunger to learn. I lecture to medical schools often, and I see a real interest and thirst to know more about these racial health disparities, to understand the real story, what is going on in communities, what happens to individual people of color, especially Black people, when we enter the healthcare system. And I think that bodes well that the next generation of physicians, nurses, midwives, and certainly public health policymakers will be different, and will not be having the same kind of blinders that their previous generation had.
So I read an article about you, Linda, that described you as a disciple of the gospel of racial uplift. I'm not sure, maybe you can explain what that means, but the article went on to talk about how you believe that Black people could pay better attention to their own health, and that would be one way that we would improve our health outcomes. And you wrote Body and Soul, the Black Woman's Guide to Physical Health and Emotional Well-Being back in 1994. Have your views changed since the time that you wrote that? And just tell us what it means to be a disciple of the gospel of racial uplift.
I think it just meant that when I looked at these racial health disparities, I looked at, why are Black people living fewer years? Why are babies dying more often? Why are these things happening? I thought, if I can just tell individual people sort of, like what to do, and how to be better individually, how to eat better, how to exercise better, how to have excellent prenatal care, even how to advocate for themselves in the system, that those numbers would change. I agree still that telling individual people and just having these discussions about being better it is good. Everybody should take good care of themselves, but that's still not going to change the whole, sort of the demographic, our demographic look at it. Like, why are we as a race doing poorly with racial health outcomes? That will not change even if individuals are doing their best, because it's a systemic problem. It's an institutional problem. And if you don't know how to frame the problem correctly, then you can't find the right solution. So I definitely have changed from that, but I've never veered from individuals should take good care of themselves, which I completely believe.
Tell us about this encounter you had with Harold Freeman. Again, I read that was a moment for you, like an aha moment after this encounter with the surgeon.
Dr. Freeman is an amazing physician here in New York. He was at Harlem Hospital, and he was a cancer specialist. So I met him when I was in public health school many years ago. And I was so interested in his work because he was the first person to say to me, if you frame racial health disparities only as a problem of poor or impoverished Black people, you will be incorrect. He took me on his rounds one day at Harlem Hospital, and I remember there was a patient who had come she left work early, a Black woman had left work early to come to have her breast examined. And she had a job. She had a really good job. She comes in and she has a lump that is so advanced breast cancer, that she could not have not seen it. And Dr. Freeman was really kind to her. And I came to him later because we had talked and asked her, why did you come in so late? asking in kindness. And she said, not that she didn't know, but that she said she was so afraid that she would die and leave her son motherless. So so that's different from not having the ability to pay, not having health insurance. It's this fear that she was ill and there'd be no one else left to take care of her son. Dr. Freeman said with all kindness to me and, about her, that she probably will not make it, because that's how advanced it was. She also had access to a wonderful, very experienced Black doctor. So I think that's different from saying, oh, we just lack access to healthcare, otherwise it would be fine, or we're all just don't have money or education. That's a different story. And it's a story that we have to think about in a different way.
And so what changes when you shift your frame, when you acknowledge that, yes, information, education, and awareness are critical, and that we all have responsibility for our own lives, including, our health life, our financial life, et cetera. But when you shift the frame to the system versus focusing on the individual, what do you think changes?
Well, I think the main thing that changes as far as the healthcare system is, one, as we as individuals may need some kind of advocate to go with us to the hospital system or to the medical system. So if we're one, afraid to enter it because we know that others like us or ourselves previously have been harmed, then it's good if during birth you go in with a doula. During, you're going to a cancer checkup, you have a patient navigator or someone who can provide some kind of community health worker that can provide a kind of personal touch to you, especially if you're afraid, especially if the doctor is speaking in medical jargon that you may not understand, especially if you're sitting there in a like a medical gown and you're super freaked out, you're worried about getting bad news. You need another set of ears. Maybe it's not that kind of professional, but it's your friend who is just going to go with you to hold your hand and to be the, active listener for you. And I think that's an individual solution, but it could be institutionalized if we cared about paying doulas and other community health workers who, sometimes they work for free. But often our system is not even as organized as other systems in much poorer countries around the world, because we make the assumption that just having a high-tech, expensive healthcare system solves the problem, but not if it's cold and unwelcoming and sometimes treating us badly and discriminating against us.
But isn't that, Linda, still putting the onus on the individual? Isn't that still saying to the individual, you have to be a stronger and more effective advocate, whether that's you advocating for yourself or you're bringing a partner to advocate for you, i.e. a doula or a health, navigator or promotor or a health advocate? Isn't that still saying you individual go and do something to make this system work better for you?
That is our current system. If we changed our system, one, we should have universal health access for everyone. So that alone would make improvements, but not get rid of the problem totally. So my contention isn't, right now, that's the only choice we have, but certainly changing the system to institutionalize community health workers, doulas, patient navigators, and other people like that, it would be a huge step forward in the way places like India, Brazil, countries in Africa that are much poorer than us have already done. And that would be a huge step in changing so that individual people aren't expected to navigate by themselves. And part of our system would be having these sort of helping, caring, loving people with us.
Yeah, and I just, this is such a big question, and I don't expect you to have the singular answer. No one obviously has it. Because we're talking about how do you eliminate racism at its core that's pervasive in our healthcare system as much as it is in our educational system, in our justice system and so many other systems. But I just wonder, if we're asking individuals to be loving and caring, which we know, will happen in some cases, but in other cases, we still will have those, the systems that when they see a Black person, they make assumptions, right? They make assumptions that if you're seeking pain medication, it's because you're seeking drugs. Or, I've had doctors on the show that when they see a teenage girl that's pregnant, they make assumptions about her upbringing, about her financial status. And that's the part of it. I just wonder how we ever start to change, because if I walk into a doctor's office And people, like I walk into a department store and you size me up and automatically assume I can't afford it or that I haven't been a good steward of my own health. I don't know how much that advocate sitting next to me trying to tell you otherwise, breaks through. And maybe what you're doing in terms of your teaching of those pre-med students is the best thing that we have, is trying to change the hearts and minds and perceptions of those people going into medicine.
Well, just a reminder that community health workers should be institutionalized and part of the system, the same way nurses and doctors are, and they would be the assumed paid advocate for you. But the second way is to force.
Right, but I guess my point, let me just stop you right there. My point is that paid advocate could be a person that has the same beliefs as those that work in the healthcare system. Just because
the smart thing about community health workers, as they are in other countries, is that they are they're from your own community. So, I've seen them in Philadelphia, and they were working with Black mothers of children with asthma. They were all Black mothers. So they were going in with a kind of a sympathetic lens. They were Black or brown mothers. But the second thing is that in the state of California and other states, there is mandated anti-racism or anti-implicit bias training that is part of the system. It's part of continuing medical education in California. If you work with a Black birthing people at all, you have to go through some kind of this training. And now it's to all physicians and other healthcare providers in the state. And that's one, but that's new. And so we don't know how well it's worked. We don't know the extent of the training or what kind it is. I don't know if it's, a computer program that you're looking at, but still this is an intentional way to say this exists. You can't just change the systems and improve the clinical part of it or the technical part of it. You have to work with individual human healthcare providers to train them to not be racist. And that is in other states as well, following the model of California. So I think that's something, again, to look at, lift up, and celebrate and study.
Yeah, no, absolutely. And California, as California goes, so does the rest of the nation. And that model hopefully is starting to break down some of those barriers. What do you want people to take away from this important piece of work? I mean, Under the Skin, it's been named a New York Times top 10 book. The reviews have just been incredible. I've read, praise for the book from, academics, from even folks like it over at Oprah.com. So the praise has been wide, and it's been incredibly positive. So what's your hope that people take away from the book?
Well, it was funny because I used to think that I used to only say, I hope healthcare providers and those who work in medicine and those who make healthcare policy really read it and understand that the structural and institutional issues. And then my daughter, who is like a young person, said to me, Mommy, I don't think you should only say that. Why don't you, your stories really, the individual stories really confirm some of the experiences real people have had in the system who are blaming themselves, who feel like they're doing something wrong. And so you need to remind people that your book lifts up people's real experiences. And because I'm all about evidence, research. And at some point, this compilation of people's real life experience becomes a form of evidence that we can't turn away from.
Yeah, those oral histories are critically important. They're just as important as the research that academics do at universities. And those real stories, help people realize it's not me, right? Like I read a story in your book and I say, wow, I had that similar experience. What are some of the common myths, Linda, that you study, that people will find in the book that will help, that you dispel, right? Myths about Black people and our health that you hope this book does dispel?
Well, one of the things is something you mentioned earlier was the idea that we have some kind of superhuman power against pain. And that myth started during the enslaved times, and it was pushed by doctors, physicians, scientists, people who were getting published in medical journals, people who were giving talks at universities, and they were saying, as though it were a fact that we have superhuman pain tolerance. It justified Dr. J. Marion Sims, who operated on enslaved women. He was a OBGYN. They still have this thing called the Sims specula, which is shocking. Someone just told me that. And that myth caused him to really harm enslaved women by doing surgeries without any kind of anesthesia. Fast forward to today, there was a study, it was 2016, that found that out of over 200 white medical students and residents, 40% believed at least one myth, including the idea that we have this superhuman tolerance against pain. That also, it's not just physical pain, but emotional pain. And so that's the reasons I believe maybe people aren't listening to Serena Williams, because there's a lack of empathy. And there's this idea that she's super strong, especially high, sort of underscored by her athletic talent, but also Dr. Susan Moore. There's a kind of a lack of sympathy and an assumption of strength. You don't need pain management. There was another study in 2019, and it was among Black women and white women getting C-sections. And even though the Black women at some points complained more of pain, their pain was ignored and they received less pain management. At some point, if you're having a baby and you need a C-section, which is major surgery, that cannot be drug seeking. It is real. And if your patient tells you they're in pain, you have to listen. But if this old myth left over from centuries ago is still floating around in society and in the minds of physicians and other healthcare providers, it turns into a problem.
I guess I'm still struggling with how we get some of these institutions to accept, because there are a lot of institutions that are in denial that, one, that racism even exists in our healthcare system. I think it was 2021, right, where the journal JAMA, this important medical association, tweeted that no physician is racist. So how can there be structural racism in healthcare?
Well, specifically with that, it was interesting because I saw that tweet, and it was part of a podcast as well. Those two people involved are no longer working there. Oh. And so I think that's a really, they got in trouble for that. And at the AMA specifically, there's a wonderful Black woman physician who runs the health equity arm, and that's new for her. And it's a new sort of like initiative. It happened after George Floyd. It's sad that this man has to be murdered in public view in order for the rest of the country to understand that racism exists. It happened after COVID, sort of like, we don't need a pandemic to prove these things, but still I see movement. And, the American Medical Association apologized for its past treatment to Black physicians. And I think that is really important, that they had been pushed aside or ignored or undervalued in the past. And that apology, I don't think apologies help everything, but it is something.
Well, apologies are a good first step, but then the question is the action. What are you going to do beyond the apology in terms of accountability? So acknowledging the, racist past is a great first start, but then the next question becomes, and for the American Medical Association, what is happening beyond the apology to ensure that, to the extent possible, racism is rooted out of our healthcare system. And I talk to so many Black people who, say they can't find Black doctors. There's just not enough. I think, 2%, 3% of the nation's doctors are African American, even fewer of those are Black women. So it's the notion that you're going to be able to find a Black doctor in every city, every county, every rural area of this country is not likely. And that a lot of Blacks still go to white doctors that they feel are incredibly dismissive of their pain and dismissive of their history, and still buy into this notion, like former Surgeon General Adams, that it's our lifestyles, right? That we drink too much, we smoke too much, we're too sedentary, that our lifestyles are the causes of our health issues. So I hope this book, helps those healthcare professionals who are making decisions. We need those folks who are deciding the curriculum for medical school or deciding who even gets accepted into medical schools, start to really look at how the medical profession has to come to grips with this. And we know people don't like accepting that, they're a part of a racist structure, that they take that personally, right? They like, oh God, I'm not a racist. People are quick to say they're not a racist, even though they may be engaged in racist type policies. I wanted to ask you though about 1619. I know you're a contributor to that project. We know that project is loved in many circles, but it's also very controversial in other circles. So, and I know this book has gotten great reviews, but have you had any pushback, like any of the kind of pushback we saw and continue to see against the 1619 project? Are you seeing any of that pushback with this book?
Occasionally I get pushback from older white physicians. And at this point, I know this material so well. I don't, it's like I'm just playing the dozens with someone who has never played. And so it doesn't really bother me. I try not to weather myself by getting into arguments and getting my blood pressure and heart rate raised by arguing with people who are ignorant. The train is out of the station for this, I think. There are already changes in medical school curriculum among medical students, in professional organizations, and among patients themselves, who, now that it's clearer that it isn't always our fault, we're able to speak up. There's a lot of movement for people to become community health workers and doulas and things like that, even before it's institutionalized in our system. I'm also a glass half very full kind of person. And so I'm really hoping that, like my daughter said, is lifting up the stories of people, lifting up the positive, sort of showing that and modeling for that is going to be useful as time goes on.
Are you seeing any of those studies? There were a lot of studies done that validated this notion that it was Blacks, our diets and our lifestyles, which, caused us to have higher, risk factors for hypertension or diabetes. So, some of this isn't just tropes and myths. There were actually university-based studies. And, maybe some of those were done through an anti-Blackness lens, but I do, I am concerned about some of those things. I'm thinking about, I guess there was, I remember Dick Gregory, he was, one of these big proponents about Black people needing to change their diet and going on this, this kind of natural diet. Or any of those studies that kind of predate this awareness about the structural racism, or any of those problematic in trying to get medical institutions and people in the medical profession to accept the pervasive nature of racism?
I think that the studies are flawed if they say Black people need to do this, individual Black people need to do this in order to change the health status of the Black race. That is wrong. Everyone needs to eat better. It's not just Black people. Every single human being should be eating with a lot of vegetables. We should be drinking a lot of water. We should be doing at least 30 minutes of exercise several times a week. All of those things are correct. The wrong part is when it's only Black people, we're the ones who need to do this, when it's saying that as a race, we as individuals can change without a thorough examination of the systemic problems that are against us. So that's my issue with it. It's not untrue that we should, as individuals, eat right and, be educated when we go into the medical system and take good care of ourselves when we're pregnant. But it's not going to entirely change the health status, our health status as a race in America, unless something else happens.
And just lastly, Linda, why is this good policy for the country, not just for individual Blacks? Like, why is it important for the country for Blacks to have better health?
Well, if you look at our health status as a country, it's not just Black people who are doing poorly. If you look at us, America as a whole, we pay the most for healthcare, $12,000 per person per year. We have advanced technology. We're the richest country in the world, yet our health outcomes as a country, as a whole, are worse than every other wealthy country. So money isn't buying good health care because we're not looking at the problems in a way that is real or true.
Well, thank you so much for writing this book, Under the Skin, The Hidden Toll of Racism on American Lives and on the Health of Our Nation. Such an important book at an important time while we're having this kind of racial reckoning conversation that has been taking place in this country since George Floyd was murdered in March of 2020. Books like this, I think, only help us have a better understanding of the systemic racism that's pervasive in so many of our systems, and hopefully move us to a place where we really are willing to look at not just the problems, but real thinking creatively about some of the solutions. Best of luck. I know you're on a book tour with the book, and I'm sure you'll be back out on the road. Lots of folks interested in this book, from healthcare professionals to everyday people, because all of us have had some experience with the healthcare system. And I think the book, as your daughter said, tells such powerful stories that will resonate with anyone that has had any kind of experience with our healthcare system. So again, thank you for sitting down with me.
Thank you. I've enjoyed speaking with you. Take care.
I want to thank Linda Villarosa again for writing this important book and for just taking on this really serious and pretty complicated subject matter. And although there's been a lot written about the intersectionality between healthcare and race and social justice, I find this book to be one of those that really speaks to everyday people. You don't have to be a healthcare professional. You don't have to be a doctor or a medical student or someone contemplating going into medicine. I think to find stories in this book that will resonate with you. If you've had any experience with the healthcare system, this is a book you want to read. I think it will help you understand your own healthcare issues, and also, as Linda talked about, help you know how to get the best out of your healthcare system, whether it's taking a healthcare advocate with you. I was just having a conversation with a relative of mine that's going through chemotherapy, and I was encouraging her to take a relative with her to her doctor, because oftentimes when you're sitting before a doctor, you are intimidated yourself by the information. You're perhaps emotional, particularly if they're giving you information that may be a little negative, and you're not always in the best place to hear the advice that's being given to you, and you can't ask those critical questions. So until we address the systemic racism that's so pervasive in our system, we do have to take it upon ourselves, and that means our collective selves, to be our best advocates, find those people in our community, whether it's friends or neighbors or family members that can, accompany us to medical appointments to make sure that, if a doctor is being dismissive or somehow marginalizing us or our pain or our experiences, there's someone sitting next to you that can say, wait a minute, no, I need you to slow down. I need you to listen to his or her question, and we need you to explain it in plain language. We need to, leave this office with a better understanding. And sometimes just that level setting will make a world of difference in the information you receive from your healthcare provider. So again, thanks to Linda for this book. Make sure you pick it up. A great holiday gift book, Under the Skin, The Hidden Toll of Racism on American Lives and on the Health of Our Nation. We'll be safe out there. Remember, we're all in this together.